Hello. My name is Jones, and today we are going to look at antenatal care. Okay, so antenatal care can be defined as supervision and management that is offered to a pregnant woman from confirmation of her conception to the beginning of her labor. When we talk of focused antenatal care, we are necessarily looking at the basic antenatal care that is given to all pregnant women that emphasizes on the quality of care rather than the quantity or frequency of visits. That is, in which every pregnancy is considered to be at risk for complications. This necessarily helps to meet quality, holistic, individualized care with the aim of attaining positive maternal outcomes and client satisfaction. Since every pregnancy is a risk, focused antenatal care relies on evidence-based and goal-directed interventions that are appropriate to the gestational age of pregnancy. With that discussed, let us look at recommended minimum antenatal care schedules. Evidence shows that quality basic antenatal care can be provided in 4 focused visits at key times during a pregnancy. The first visit should be within the first 16 weeks of gestation. Then the second visit should be between 24 to 28 weeks. Then the third visit should be after 32 weeks. Then the fourth visit should be after 36 weeks. Please kindly note that depending on the policy of each and every country, you may find that visits might be more frequent in trying to rule out any risks within pregnancy. However, further visits can be arranged depending on the individual client needs and the company, also not necessarily company, but the national policy. Let us now look at the components of focused antenatal care. When you're talking of components of focused antenatal care, there are 4 components that we talk of. 1 or A is early detection of complications and prompt treatment. B or 2 is disease prevention. C or 3, that is birth preparedness and complication readiness. D or 4, that is health promotion. Let us look in detail these components of focused antenatal care, starting with early detection and treatment. Although most pregnancies are normal, early detection and treatment of problems that can bring about complication is very, very important. Focused antenatal care promotes a targeted assessment during which the skilled provider, midwife or nurse, interviews, examines, and tests the woman to detect the signs and symptoms of pregnancy and also detect any health problems that the woman might develop during the pregnancy. Then B is prevention of conditions, complications, or prevention of diseases in general. To prevent certain conditions, there should be safe and simple, cost-effective interventions that should be carried out so that the woman does not get any diseases that may affect her and the unborn baby. So they are given tetanus toxoid immunization to prevent tetanus, and there is also provision of iron and folate supplementation to prevent iron deficiency, which may lead to severe anemia and complications like preterm birth, congenital abnormalities, and intrauterine growth restriction. The other ways of preventing of conditions or diseases during pregnancy is giving of intermittent preventive treatment with Fancida. Okay, so this is to prevent malaria in pregnancy, and to supplement this in preventing malaria, women are also given insecticide-treated bed nets to prevent malaria. Then there is also The intermittent preventive treatment for hookworm infection through provision of either albendazole or mebendazole during pregnancy. Okay, then we can also look at the other component of focused antenatal care, which is health promotion. Throughout antenatal care, health education and counseling are done to make sure women are able to take care of themselves. It is the duty of a skilled provider to ensure that adequate information is given to these mothers. Some of the information that can be given to these mothers during pregnancy and focused antenatal care include preparing a birth plan, recognizing danger signs in pregnancy and during childbirth, the issues of HIV/AIDS and pregnancy, malaria in pregnancy, nutrition that is very important in pregnancy for a healthy mother and also for a healthy baby, activities and exercises that can be done during pregnancy, childbirth and infant nutrition, including breastfeeding and replacement feeding, if at all a woman chooses the other option of not breastfeeding, postnatal care, and also family planning services that are available after the woman has given birth. Alright, and then the fourth component of focused antenatal care is birth preparedness and complication readiness. If a woman is well prepared for a normal childbirth and a possible complication, she is more likely to receive the skilled and the timely care that she needs. This can protect the mother and the newborn's life, as all that is needed in saving the life of the mother and the baby will be within reach. It will also allow for time to develop a birth plan, which may include making arrangements of a normal childbirth. Okay, so in our discussion, we have talked about developing a birth plan. So when you're talking about developing a birth plan, it includes the skilled provider to attend to the birth of the child, also coming up with a price of a birth for the child, depending on the needs that have been assessed for this pregnancy in this woman. Okay, the issue of consideration for transportation of the pregnant woman to the skilled provider, the issue of ensuring that the funds are ready when the woman is ready to deliver, so that she can easily book up a cab and go to the hospital and be attended to, unlike at the last minute panicking. So these funds needs to be available. Then also the need for a support person or birth companion during this time. Then items are needed for a clean and safer birth for the newborn, also like clothing and the likes, also can be discussed during the birth plan. So the woman is going to have a suitcase where she's going to put all the clothes that the baby might need or the baby will need when the baby is born. Hence, we also have some arrangement in case of complications. So some arrangements in case of complication include recognition and response to danger signs, decision making in emergency situation, emergency funds, okay, for purpose of complications, and also emergency transportation, like use of ambulance for a woman to deliver at another hospital. So in preparation for the birth plan, a woman mostly will have a suitcase where she's going to buy certain items for herself. But when there are complications, the hospital has also an emergency plan for women with possible complications to be attended to at a higher level a service provider. Okay, so now let us look at activities that are carried out in antenatal care. The activities are carried out at antenatal care may include the following: registration and booking, history taking, physical examination, investigations and tests, medications, referrals, advice and information and education, and then recording. So when we talk about registration and recording, when the woman reports for antenatal care booking, she has to be registered for the purpose of record keeping and documentation. Then we talk of history taking. The following are the preliminary points to note during history taking. You have to prepare the necessary equipment, greet the woman respectively and introduce yourself, offer the woman a seat and ensure privacy, explain the procedure and encourage her to ask questions, get her permission before you begin the procedure, and also listen to what the woman has to say. So this can be done during history taking. Then detailed procedure for history taking. History taking is a cardinal during antenatal booking for a nurse or midwife to get to know the client well. It is a means of assessing the health of the woman to find out any conditions which may affect the child or may affect childbearing. The history has to be comprehensive, and key issues should be considered in history taking, and this may include social history, family history, personal medical history, surgical history. So these are just some of the things that should be considered. When we say social history, here we are looking at the name, age, marital status, religion, residential address, occupation and education level for self and spouse, the social habits and environmental factors. This history is taken to identify rationale for follow-up and health education. Age less than 18 years or greater than 35 years are considered as high-risk mothers. You can ask her how she is feeling and respond to danger signs, if any. Okay, the other detailed procedure for history taking is family history. This kind of history is taken to know the genetic predisposition to certain diseases. You can ask the woman if there is any history of the following in the family, that is diabetes mellitus, hypertension, asthma, epilepsy, sickle cell disease, and mental illness, since they tend to run in families. You can include a history of pulmonary tuberculosis, either contact and the likes, because of let's say the mother being at risk from such diseases due to low immunity that happens in pregnancy. And then you can also ask for history of multiple pregnancy, okay, especially from the maternal side. Okay, then the other component that is important in detailed procedure for history taking is that of personal medical history. You can ask the woman if she has ever suffered from any medical condition as outlined in family history, and in addition ask about history of sexually transmitted infections, like also having urinary tract infections or hepatitis. Former illnesses may have damaged certain structures or organs, which could give risk to complications during pregnancy and labor. Hence, the reason for us asking for personal medical history. And then the other part which is important in the detailed procedure for history taking is that of surgical history. Okay, you can ask the woman whether if she has had injuries or operation involving the pelvic bones, spine, or lower limbs. These could alter the pelvic diameter and angle of inclination that may lead to several pelvic disproportion. You can ask about previous abdominal surgery. This can lead to adhesions which can restrict the normal growth of the pregnancy. You can also remember to ask about history of blood transfusion to exclude ISO immunization if the woman is rhesus negative. Okay, so with this detailed social history to do with family history, personal medical history, surgical history, we can now look at past obstetric history. Here you can ask about parity and gravid state. You can ask the woman about a record of previous pregnancies and labor or the outcomes. Okay, was labor premature or post-mature, spontaneous or induced, history of instrumental deliveries, previous obstetric history or complications. So in past obstetric history, you also ask about the gravid state of the mother, and then you can also look at menstrual and contraceptive history. You can ask about age at menarche, menstrual interval and breeding pattern. You can ask about method of contraception, when and how long, and reasons for stopping. Then you can also ask for present obstetric history. Here you can ask the woman for the first day of the last normal menstrual period, and then calculate the gestation age of the pregnancy and the expected date of delivery. Okay, so this has to do with past obstetric history. Okay, then so in past obstetric history, we look at everything that is related to pregnancy. Then you can also ask the woman about health and other concerns during pregnancy, such as fatigue, drowsiness, headaches, sore tongue, loss of appetite, nausea, vomiting, and edema. You can also ask the woman about her dietary intake, what type of foods, how many times a day, and any ingestion of non-food stuff or abnormal craving for certain foods, which is mostly seen in women, which is termed as pica. Okay, you can ask the woman about social support and record responses, because this is very important to know how she's being cared for and how she's managing the pregnancy. So the main support persons like the husband, father, or mother, okay, and also the availability of money for food, transportation, and baby supply. So this is very, very important. Okay, so when this has been done, you can proceed to do a physical examination. Okay, so in physical examination, it should be done under strict privacy, and you have to tell the woman that it's going to be done under strict privacy and encourage her to ask a question. You can listen to what the woman has to say prior to the physical examination. As a nurse, you have to note the stature, the height, and the weight. Okay, when you talk of the stature, if a woman has a small belt, she is likely to have a small pelvis. Okay, when you talk of gait, as the woman walks in, observe any deformities, stunted growth, limp, and such things. These may indicate disproportion in the pelvic diameters. A pregnant woman tilting backwards with a large abdomen may be carrying multiple pregnancy or very large fetus. Then on height, 150 centimeters or less needs special care, because in most instances, the shorter the woman, the smaller the pelvis. Okay, then when you talk about weight, the average weight again during pregnancy is about 12 to 14 kg. A pregnant woman is expected to approximately gain weight as follows: 2 kg in the first 20 weeks, then 0.5 kg per week until term. So this then will culminate to 12 to about 13 kg total weight gain. So after all this has been done, then you can proceed on to do urinalysis, blood pressure, and also do a head to toe examination, and then also do an abdominal examination to also confirm pregnancy and also establish gestational age of the baby. So this also can be done. So when you're talking about a physical examination, there is a lot that can be done on head to toe, and also the abdominal palpations that are done. Okay, so on the abdominal palpation and other things that are involved in physical examination, what we can simply say is that when you're doing head to toe examination, okay, here you can assist the woman to get onto the examination couch, wash your hands thoroughly with soap and water, and dry them, then start the examination. So when we are looking at the head, you look for underknowledge, hair, and general cleanliness. When you are looking at the eyes, you examine for pallor and jaundice on the conjunctiva by opening the lower eyelids and asking the woman to look up. On the nose, you examine for nose polyps, and the ears, you examine the ears for polyps and any discharge. To do with the glands, you can palpate for enlargement of periauricular lymph glands, submandibular lymph glands, and cervical glands around the neck. You can palpate the thyroid gland too, and ask the woman to swallow while your fingers are slightly placed just below the larynx. Enlargement of gland suggests infections, chronic illness, or maybe to the effect of estrogen on the glands, and also hyperthyroidism, which can lead to goiter formation. Then for the issue of the mouth, you can ask the woman to open the mouth, check for signs of anemia on the lips, mucous membranes of the mouth, gums, and the tongue. You can also check for fissures on the tongue, oral thrush, and sores on the tongue. You can take note of dental caries and find out if the teeth are painful. On the hands, starting with the furthest arm, you can examine the arm for signs of anemia on the palms, poor venous return on pressure of the nail beds, and also examine for signs of edema. You can ask the woman to make a fist with each hand, a feeling of tightness in the knuckles in the absence of pitting edema would be suggestive of occult edema. You can check for any physical disabilities, symmetry of the arms, and lastly palpate the axilla for any enlarged lymph nodes. On the breast, for the breast, you can examine for presumptive signs of pregnancy and suitability for breastfeeding, and check for lumps or swelling of the breast. So on the breast, you can examine for presumptive signs of pregnancy, that is Montgomery's tuberculosis, darkening of primary areola and secondary areola. Then suitability of breastfeeding, this is more significant in primary gravida. This includes expression of fluid which shows that the ducts are patent, and then the presence of a clear fluid, milky fluid, colostrum are presumptive signs of pregnancy. You can check for lumps or swelling in the breast, and then for the lower limbs, you can start with the furthest leg and examine the legs for signs of anemia. On the soles, there will be poor venous return, and then on pressure of the nail beds, you can check for capillary filling, and also examine for signs of tibial, pedal, and ankle edema. You can check for any physical disability, and asymmetry of also the legs. You can also check for varicose veins, which are very common amongst some disorders that are seen in pregnancy, and also rule out calf pain. Then when we come to abdominal examination, okay, so abdominal examination will be done through inspection, palpation, auscultation, and the likes. So in abdominal examination, on inspection, you look for shape, you look for size, you look for skin, and you look for scars. Okay, so these are the 4 S's that you inspect for: shape, size, skin, and scars. So when you look at the shape, you need to note the contour of the abdomen. Is it round, oval? Is it irregular or pendulous? Size should correspond with the supposed period of gestation. Then the skin, you check for dark line of pigmentation known as linea nigra, and you can also look for stria gravidarum. On the scars, you can check for scars on the abdomen, which can indicate a previous surgery, operation such as laparotomy or cesarean section. Okay, so now when it comes to palpation, you can measure height of fundus to determine how old the pregnancy is. You can use a measuring tape or finger breadth. So when you talk of 10 to 12 weeks, it should be slightly above the symphysis pubis. When you're talking of 16 weeks, it should be halfway between symphysis pubis and the umbilicus. When you're talking of about 20 weeks, the height of fundus should be at the umbilicus. When you're talking of 28 weeks, 3 fingers breadth above the umbilicus. When you're talking of 36 weeks, it should just be below the Zipf's sternum or just below the diaphragm. You can do fundal palpation to determine lie and the presentation, and also do lateral palpation to determine the lie, attitude, and the position. Then you can also do deep pelvic palpation to determine the presentation. Okay, then from that, then you can move on and do auscultation. In auscultation, you listen to the fetal heart rate and rhythm. You count for 1 complete minute to ascertain regularity. Okay, with this done, you can move on to do perineum examination and also examination of the back. When you're doing a perineum examination, you can observe the vagina and the perineum for any abnormal rash or sores. Observe for foul-smelling abnormal vaginal discharge. If present, may signify a sexually transmitted infection or other conditions. You can check for varicose veins around the vagina, and also check for any genital mutilation. Then at the back there, you can turn the client on one side to view the back and observe a vertebral column for any abnormal curvature and inspect the anus for the sores. Then laboratory tests can be done. Urine for protein and glucose, issues of eclampsia, and then blood test can be corrected. Samples to rule out syphilis, to also check for HIV, to check hemoglobin, and also blood group, and the issue of rhesus blood grouping. Okay, then you can move on and do treatment. The following are the drugs that are given, okay, to pregnant women. We have intermittent presumptive treatment. There are 3 doses of Fansidar, of which, depending on the policy, after 3 months, it can be given monthly. Okay, that is the for Fansidar. Okay, depending on the policy, because policies keep on changing. There, so otherwise, the Fansidar is to be taken by a woman under direct supervision of the nurse. Then the tetanus toxoid injection should be given up to 5th dose. This is to prevent adult or neonatal tetanus. Then mebendazole 500 milligrams per oral stat is given for deworming purposes. Okay, and it is given as a single dose with a minimum gestation age of about 20 weeks. So daily doses of ferrous sulfate at 200 milligrams and folic 5 milligrams are given to prevent and correct iron deficiency anemia and folic acid deficiency anemia. Okay, so with all this done in physical examination, let us now look at information, education, and communication. Okay, it's abbreviated as IEC. So giving of IEC. So when you're giving IEC about pregnancy, you can talk about nutrition in pregnancy. The need for high demand of food in pregnancy is quite high. So you talk about the improvement of nutrition in pregnancy. And you talk about all those things, cultural issues that may affect nutrition in pregnancy. Look at those that are very essential in trying to promote nutrition in pregnancy. You can talk about hygiene in pregnancy. You can talk about danger signs in pregnancy. You can look at also minor disorders in pregnancy so that a woman can understand that such things may be seen in pregnancy. You have to talk about in the IEC birth preparedness and complication readiness. You can talk about malaria in pregnancy and the prevention of malaria. You can talk about parent to child prevention of HIV. You can talk about the importance of antenatal care. You can also educate the women about signs of true labor. Okay, you also educate them about family planning, birth registration, and also educate them about child immunization. And you can talk about a lot of other things. Okay. So, recording of findings, record or findings and information that you do on the antenatal card and a safe motherhood register for purpose of continuity of care. So, in this discussion, comprehensively, we have talked about antenatal care. So in talking about antenatal care, we defined antenatal care as a supervision and management that is offered to prevent women from confirmation of conception to the beginning of labor. Then we talked about focused antenatal care as the basic antenatal care that is given to all pregnant women that emphasizes on the quality of care rather than the quantity or frequency of visit, in which every pregnancy is considered to be at risk for complication. Then we looked at recommended minimum antenatal care schedule, of which the first visit is within the first 16 weeks of gestation, the second visit being between 24 to 28 weeks, the third visit being after 32 weeks, and the fourth visit coming at 36 weeks. Depending on national policies, these can change to almost monthly. Okay, this is for purpose of improved care, especially for women with these observed risks. Then we have also talked about components of focused antenatal care, which talks about early detection, disease prevention, which talks about birth preparedness and health promotion. We expanded this discussion on this and then went on to talk about developing a birth plan and the components that are important in the birth plan. We have also talked about activities that are carried out in antenatal care, which included registration and booking, history taking, physical examination, giving of medication, and referrals. Then we talked about registration and booking. That is when women report for antenatal care booking, they are registered for the purpose of record keeping and documentation. After that, we talked about history taking and looked at detailed procedure for history taking. So thank you very much for listening.